My name is Haripriya Maddur. I'm a transplant hepatologist at the University of Arizona in Tucson. Non-alcoholic fatty liver disease was the previous umbrella term. So these were patients who had liver disease that basically did not have alcohol as a component. And it was stratified as being non-alcoholic fatty liver or NASH. So NASH is a subset where patients have inflammation, which could then lead to fibrosis or scarring, which then could lead to patients developing cirrhosis. In June of 2023, however, there was a change in the terminology. So patients that were previously known to have NAFLD were then changed to having MASLD. So that's metabolic dysfunction associated steatotic liver disease. So that's basically patients who have hepatic steatosis with one of 5 components of the metabolic syndrome, being an elevated BMI, elevated blood glucose or diabetes, elevated hypertension, as well as elevated triglycerides or low HDL. So that's actually what MASLD is now. And then patients who have evidence of inflammation are no longer called NASH, they are now called MASH. But it's actually really important to understand that the umbrella term has changed somewhat. So the umbrella term now is steatotic liver disease, and you can then either have MASLD, which I already described, or you can then have MET-ALD. So MET-ALD is if you have MASLD with alcohol use, specifically 20 to 50 grams of alcohol daily for a woman, or 30 to 60 grams of alcohol daily for a man. In patients who have significantly more alcohol consumption, those patients are then labeled as having alcohol-related liver disease. And that's important to note because alcohol-related liver disease can also lead to steatosis, and that's why it's still stratified under the umbrella term of steatotic liver disease. In patients who have steatosis, but they don't have evidence of metabolic dysfunction-associated liver disease, it can also then be related to medication. So you can have drug-induced liver injury as a component, or you can actually then have cryptogenic steatotic liver disease. So it's a little bit more of a complicated answer, but that basically helps to determine the difference between MASH as well as metabolic dysfunction-associated liver disease. So most of the risk factors essentially correlate with a metabolic syndrome. So obesity, type 2 diabetes, hypertension, and hyperlipidemia. These are the major risk factors that then lead to MASLD. So I'm going to start first with the diagnostic tools, and then I'll talk about the differences. So the gold standard for diagnosis is actually liver biopsy. But liver biopsy is riddled with a lot of morbidity, and it's not feasible to biopsy all patients given that fatty liver disease is actually the most common liver disease. So a lot of the risk stratification is based off of non-invasive testing. The easiest to perform is actually the FIB-4 test, which is comprised of patients' age, AST, ALT, and platelet count. And that can determine whether or not patients have advanced scarring versus not. And those with advanced scarring are likely to have MASH. Other tests, one of the ones that I prefer to use, include transient elastography. And transient elastography is a fantastic tool. It actually sends sound waves into the liver, measures how fast they come back, and those patients who have a faster return of the sound waves typically have a stiffer liver. It's not a precise test because there are things that can cause false elevation, specifically those patients who are obese or those who have hepatic inflammation. So if you're thinking about your patients who are drinking heavily at the time of testing or who have viral hepatitis, you may have a false positive transient elastography. Nonetheless, it's a great tool still within the clinic to determine whether a patient has advanced fibrosis and likely MASH. Other tests that are slightly more accurate along the same vein are MR elastography. And there are other serum tests, specifically the ELF score, that is being used more readily. How does this differ from other screening and diagnostic tools from other liver diseases? Well, going back to transient elastography, we actually have what's called a CAP score. So that's controlled attenuation parameter, and that can tell you a quantification of the amount of steatosis within the liver. Similarly, MRI has similar capabilities with the MRI-PDFF, and so those are the diagnostic tools that differ from other liver diseases. And you can then use these one step further. There are now the MASS score and FAST score that then are comprised of both MR elastography or transient elastography with other non-invasive laboratory testing to get a more accurate test of fibrosis within these patients and help you not only diagnose MASH, but also those patients who have advanced fibrosis or scarring. I think one of the most common challenges is lack of referral. I think there's still not a lot of awareness about the presence of steatotic liver disease, especially because quite often when people are looking at elevated liver tests, they're looking at laboratory-based ranges, which are population-based, rather than knowing the upper limit of normal of ALT. And so for a woman, an ALT of 19 to 25 is typically the upper limit of normal, and for a male, the upper limit of normal is typically 29 to 33. So often these patients have liver tests that are in the 40s who may have early signs of steatotic liver disease, but they're not captured early because of the population-based ranges and lack of awareness of what normal ranges are.